It is 12 o'clock, and it's time for another exciting moment in data as we share our presentation today on data in the real world, using data to drive decision makings in clinical program development. My name is Travis Atkinson. I'm here with TBD Solutions, and I'm also here with my working partner, Sarah Bowman, and we're going to be talking about the ways to use data to make decision makings in a relevant example. So the last several webinars that we've hosted, we've talked about different ways to use data, different types of people that exist in your organization and how they look at data. And today we're going to try to take that into something concrete and talk about how you could use this in your program development endeavors. So we're going to start with a problem, and we chose today to focus on inpatient psychiatric costs. So the scenario here is that you are a clinical supervisor, you have a busy job with lots of things to do, no shortage of things to do, no shortage of stimulation through different job responsibilities, and your supervisor comes to you because supervisors are just inherently larger people. So this person on the left is your supervisor, just a giant of a person, and they bring the problem to you that there is a problem with how much money we spend on our psychiatric costs. So from there, you're left with basically to come up with a solution on your own. So you're not necessarily told what to do, you're just told that there's a problem. And so from there, you might say, oh my goodness, I've never been tasked with this type of issue before, and so you're left to make some decisions on what to do. So the first step is in analyzing whether this truly is a problem. So when you think about the psychiatric costs and how they're affecting your organization's budget, it's good to go into depth and ask some questions. And so we took the triple aim and applied it to this problem of high expenses with psychiatric hospitalization, and tried to break it down to say, okay, where is the experience of care, and I apologize here. So with the experience of care, first of all, are individuals satisfied with their care? Are they getting their needs met from their case manager, from the medication clinic that they go to? Is there timeliness of access to care? So you think about the time from when they schedule an appointment until they're seen. Is that a week, or is it several months? What is patient care like within the hospital? Are they receiving the services that they need, or are they going back several times? And are individuals accessing services? So are they getting the services that they are entitled to or that they're open for? Are they receiving those services? And do all of those things contribute to a person going to the hospital for unnecessary reasons? The second piece is per capita cost. So have the rates changed? Can you look at numbers from past budgets or past expenses to say, have the rates changed? What is the average length of stay right now, and how does that compare to past lengths of stay? What other services contribute to a high per capita cost? So are they going to a specialized service? Are they going to a high service like a psychiatric medical unit that they don't necessarily need, or that could be treated outside of the hospital? And how does treatment facility utilization affect cost? and how have populations changed their utilization of intensive services? So are you seeing people with an SUD diagnosis, are they accessing services at an increased rate? And is that because SUD beds have shut down and so people are naturally going to a psychiatric hospital? Lastly, the third corner of the triple aim is population health. So what are the demographics of individuals receiving these intense services? So what other information is important to know about them? Do they have comorbid medical conditions? What non-psychiatric factors contribute to hospitalization? So when we think about the social determinants of health, have there been breakdowns in family systems? Have there been breakdowns in maybe access to other support that is not related to behavioral health that contributes to this hospitalization? And then how do our utilization rates compare to other communities? Almost all of these questions can be answered with data. And so inside of this triangle has the data that can be captured from these different areas. So referral to intake process, the cost per facility, the percentage of new patient admissions, contracts, comorbid conditions. These are all things that we can currently track right now to tell us, is this a question of an unmet need in our community, or are there services that just aren't being utilized accurately?
So Travis, it's such a good point that when we look at something that we need to tackle, a problem that we think may be defined one way, that we've got to use data to really figure out what that problem is. We've really got to roll up our shirt sleeves and dig into the numbers, dig into the information available to us to make a fully informed decision about what that problem is before we can move into the solution or brainstorming of possible interventions. That's a really good point.
Yeah. So this is before we're even deciding what we're doing. We're kind of exploring all these avenues so we can really understand the problem as well as we can. From there, we will analyze the available data. We'll collect additional data. So maybe we survey for 2 or 3 months how many people would have used crisis residential, but it wasn't available. We'll do research and recognize that in this case, crisis residential services are supported by decades of research in their efficacy and their results. And we'll consider alternatives. We'll talk about are the problems that we're facing that are leading to people coming to the psychiatric hospital, can they be solved within currently existing systems, like an ACT team or another type of intervention, another type of crisis intervention. For the purposes of today's presentation, we are going to assume that our conclusion is that crisis residential is the best option for us, the best choice.
So, Travis, you're saying that what we found through our imaginary data work, because we were very thorough, of course, in our data analysis, yes, that we found that our community was not accessing crisis residential at the rate that other areas are. So we found that when we benchmarked to other CMHs and other regions, their utilization of crisis residential was higher than ours, and their utilization of inpatient was lower, and that we found that it wasn't, the increased cost that we had with inpatient wasn't because our hospitals all doubled their rates, or we started a new concurrent review process where we suddenly gave 10 days worth of OSS at once instead of 1. Like, there weren't any glaring issues there. So we've determined we have an access to crisis residential issue. We did our gap analysis, and this is what we decided we need to somehow address.
Exactly.
Okay.
Yep. So from there, we're going to move into the supervisor's dilemma. And the supervisor's dilemma is that you're being thrown into a situation in which you're not familiar with that could potentially make you feel uncomfortable. I've heard a lot of times that, clinicians like to tell that they don't always like math, and so that's why they chose the field that they did. So in kind of the same way, there might be this skill set that we embrace, that we get to use every day, but that we can't necessarily see how it defines or how it translates into another project or another expectation. So the two questions that we're asking are, how do we translate the skills we have as supervisors into an unfamiliar setting like program development? Everybody develops a program for the first time once. So even experienced developers had a time where they had never developed a program before. And so how do you exist in an unfamiliar setting, and then how do we develop new skills to achieve success? So you can see this is a fish that is very far out of the water. It's not intended to be a flying fish. This is just a regular fish feeling very awkward, just completely surrounded by air. And then also on the other side, just some building blocks, just trying to understand, how do I put this together? What are my instructions? So when we compare the characteristics of a supervisor versus a developer, the supervisor is generally emotionally balanced. They've had experience enough in the field that they're able to oversee other people's work. So that experience generally brings kind of an equanimity or a consistency to the work that they do, but really to how they respond emotionally to situations. They have to be reactive or responsive because it's very hard, almost impossible to plan for what the people that you supervise are going to face in their work. So being responsive is a part of being supportive and being able to come up with actions quickly. So it's a reactive job versus kind of more of a proactive job. A supervisor is also intuitive, so they have to trust their instincts. They have to have these instincts that have served them well to make good decisions. They have to be creative in their problem solving when they're faced with issues that they don't know what the answer is, or they know that they want to treat their people that they supervise with respect, and they want to care for them, but that might be challenged by other constraints. They also have a level of self-awareness, again, from that experience, that life experience, to say, I know what my triggers are, I know what I'm good at, what I'm not good at. They're relationship focused, so they know that the dynamics of the relationship between them and the people that they supervise is important and a key to success. And they're also complex communicators. So in the instance of a clinical supervisor, they are both taking information, they're taking into account the clinical demands of a job as well as the administrative demands, and they're translating that to the people that they serve so that they can be effective and they can help people to understand what's going on, what the bigger picture is in the organization. Now, a developer on the other side is a person who's very organized. They're proactive, so they're seeing a plan out to its fruition, but that means they're making a plan that could have a lot of steps and go over the course of several months or a year or more. They're both task-focused and project-focused, which means that they understand the importance of the task relative to the project, and they can understand that the drill down, that the details in that are just as important as the entire project itself. They're dynamic. They're able to be adaptive and get and make do in a lot of different situations, and know that even if things get in the way, that their goal is still the same. Having external awareness, so knowing what factors are going to be threats to the timeline, the timeliness of the project, the success. They're negotiators, so they work with a lot of different departments, a lot of different types of people to get things done. And so in that sense, they're also diverse communicators. So they're talking to finance and IT and any department or any person that is affected by the development of a program or of a service. They have to be able to know the language that those people speak and how to be effective in how they talk to them.
Travis, I think you brought up a really good point about the task and project focused, and I want to talk about, at least in my experience as a supervisor, how that was a struggle with the relationship focus, because we have to wear both these hats as a supervisor, right? Like, yay, you are a super busy supervisor, and now you have to create an integrated behavioral health program for your CMH. So I struggled when I was in that role. I was very relationship focused with my staff, wanting to make sure I was there for them, for those knocks on the door, for those, oh my gosh, I'm in session and I don't know what to do, I need your help right now type things. But when I was creating those integration programs, there were so many deadlines and work that I needed to be doing for our community partners. So the task and project focus and being organized in that was huge. But I would be pulled away from that because my staff would need something. And I was committed to that relationship. So there's a balancing act that has to be done here, right? Like these aren't all opposites or anything like that. It's just different skill sets, and we're going to have to make intentional choices about how we're prioritizing our time each day. And one thing that I would throw in is the pace. Often a CMH supervisor, I mean, you know, your day just, it is just going at a lightning speed, right? So many things being thrown at you. To oversee a project of a new program being created, that's a long-term thing. It's a marathon, not a sprint. So the pacing needs to be different, and we need to intentionally slow down enough to take time to look at data. If a clinician comes to us, we don't often have to look at data. We can have a clinical discussion and come up with a plan. But for something like this, we have to take time to look at the data. And I think CMH doesn't always encourage that because our culture is just so busy.
Mm. Yeah, and I think it's also important to just acknowledge that while you are busy, while you have a lot of responsibilities, there may also be other realities that you have to deal with. And so how do you exist in that space? It's very hard to maintain equilibrium as a supervisor and to keep things at a place where you always feel that they're under control or they're at a place where you want them to be. But it's also important to ask yourself, how am I going to handle this change, and how am I going to be okay with things being not okay, so to speak? Mm-hmm. When's the last time that you can remember that you were in a space where you didn't understand things, or that you were like new to a system or to a role, and even as an experienced person, how comfortable are you being in that space now and being open to learning new things? And so that involves changing gears. That involves just being open to saying, while I can recognize that there are some parallels or some similarities between a supervisor and a developer, but I also know that there's differences, that I'm willing to explore what that looks like to embrace that role and to learn it, to be a student again.
Yeah, to change gears, yeah.
Yep. So these are some considerations to take into account when you're deciding what you're going to do, and there are some options that we're going to talk about after we go over these considerations. Assuming that crisis residential services is the option that we want to find, then how do we kind of narrow it down even more? So the first consideration is the mission, vision, and values of your organization. So if you think about what your values are, what the mission is, is there a vision or a mission that ends up on the header of your memos or on your organization's website, and how does that contribute to what this program would look like? So if you think about the essence of what your organization or what your CMH wants to do, then how does this service fit into that greater good? Because that is going to help you to explain the service and why it's important to stakeholders, to people who are involved, to people who are curious, to the people who are going to be utilizing the service. Another consideration is mandates, and so in that first one of the first slides there, we had this boss, just with a dollar sign saying like, "Hey, something needs to change," and we get this impetus sometimes for change. It could be financial, it could be other outcomes, it could be safety, but these mandates happen, and just the essence of the word mandate, it doesn't mean that it happens in the timeline that you want it to. If you say, hey, I think in spring of 2016 I'm going to have some time to work on developing a program, unfortunately it doesn't work like that. Unfortunately, we have to be adaptive to when the demand is there or when we're required to do something. that's outside of the comfort zone. So resources is another consideration. What do you have at your fingertips? Is this something that that your organization, your agency has done before? Are you good at it? Do you know people who are good at it? Do you know other communities? Do you have good relationships with other communities? And have they done this before? And were they good at it? What do you have at your disposal? Collaborators. Who are some people that can help you in this process, both internally and externally? And what do they have to offer, and how could those relationships be beneficial for you? And then competitors, are there people who are providing this service nearby? And does it make sense to duplicate the service? Is it going to is that going to be beneficial? And then lastly, intended outcomes. What do you want to see from this program, and what would it look like if it was really good? And Sarah's going to talk a little bit more about outcomes.
Yeah, we know that in the ever-changing landscape of healthcare, the outcomes movement is huge right now. With managed care, there's increased expectations of patients, payers, healthcare organizations, and of course the ever-present pressure to lower costs. So the outcomes movement really utilizes 4 techniques. Basically, there's an increased reliance on standards and guidelines, which we see in our daily work in the behavioral health world. There's routine and systematic interval measures of patient function and well-being. It's a really fancy way of saying we have to use functional assessments now to capture at a point in time how are folks doing. And then at a later point in time, we hope to show clinically significant improvement. So we're trying to track particular clinical outcomes. There's an expectation that we're pooling clinical and outcome data so that we can then analyze that data, learn from it, have our systems learn from it, and then disseminate that information to the different stakeholders and decision makers. And that kind of gets back to the whole learning system that we talked about a few webinars ago. The clinical performance measurement, or a part of this outcomes movement, there's 2 different types of measures that we can look at. And when we're starting a new program or looking at a new way to have a need met, i.e. how do we get access for our folks in our community to crisis residential services, we're going to want some measures that are looking at process and some that are looking at outcome. The process measures are typically a little easier to construct, maybe a little less data collection and analysis, and usually easier to understand for clinicians and non-clinicians. So with a crisis residential home, for example, a process measure might be the length of time from the admission to the home to when they get their psych eval. Obviously, we would want that to happen pretty quickly. So that's looking at a process of care. Another example of a process measure, many behavioral health organizations right now are working on management of diabetes screenings for folks on psychotropic or antipsychotic medication. So the completion of a diabetic screening is a process measure. It's a part of care, and we can measure if that part of care was done or not. An outcome measure is more of a discrete, patient-focused endpoint. So it's going to be a clear measure of something that was accomplished, such as an improved PHQ-9 score. So our hope would be in our crisis residential home that the intake PHQ-9 scores are going to show clinical significant improvement compared to the discharge scores. I encourage you, if you're not familiar with the NQF measures, to get on Google and search NQF and look at their measures. I'll talk about a few of those in more specifics later in the presentation, but whenever it's possible to use standardized measures, this is the language that health plans use. So if you as a behavioral health organization are trying to set up a new service that you're going to want to be competitive in the future and sustainable, you've got to talk the language of the larger healthcare system. And so to be able to demonstrate your performance on standardized measures like HEDIS measures or NQF measures, that's going to go a long ways towards the credibility of your program.
Mm-hmm. I want to bounce back. There was one piece that we skipped over just briefly over here. All of these considerations are going to help you to make a decision as to what you want to do in the crisis residential service that you provide. And so we identified 3 options. You could develop and operate the service entirely on your own. You could develop the service and contract with a provider to provide the service, or you could purchase from an existing provider. It really depends on what the culture or the standard is where you work as to what extent of services that you would provide. So some CMHs are provide a lot of services. Other ones provide very few, and so these options are exercised by CMHs all across the state. But it's just important to know what would be best for you.
And to know what's best for you, we want to look at, in part, yes, your culture and what your organization business process typically is, but look at the data, right?
Yep.
Whenever possible, gather data to support and inform those decisions to decide what is fiscally doable for your organization, what will be sustainable, what we have the best chance at successfully meeting the persons that you serve needs.
Yep, exactly. So as we think about inputs, these items that we will need in order to be successful, the first one is staff. We've got to think, what is capacity going to look like? What is it going to look like with our team to develop this program? And how, again, we ask that question, not just how do we do this, but how do we do it well? And what kinds of staff do we have involved to make this work and to be the kind of program that generates the outcomes that we want to have. The second is time. So we touched on this a little bit. Supervisors have no shortage of things to do, and neither do the people that surround them that would be helping in this process. And so it can almost be helpful to do a reasonable analysis of how much time this type of project would take, because it will take time. It will also take money. We'll touch on this a little bit later when we start to walk our person through the steps of going through their organization and program development. But it will require a cost to be able to save in the long run. There'll be an upfront cost on developing a program. Also research-based. So how do you know that this program works? How have you heard that it works in other communities? It could be in Michigan. It could be in other parts of the country or parts of the Midwest. What materials and equipment are needed to make this happen? What space, locations, and everything that it would take to run a program like this. Also, what kind of technology? Technology is obviously more important now than it ever has been in being able to track outcomes and be effective. And then finally, partners. Your partners are going to be your inputs as well, the people who are around you. And we touched on this in an earlier slide, but they are of value. They're a commodity that's going to help to contribute to a successful product. So we're going to look back. If you remember, the initial problem here is that inpatient psychiatric hospitalization is costing your CMH too much money. And so I want to spend a little bit of time talking about the assumptions that we make in the services that are provided at an inpatient psychiatric hospital, to ask ourselves, what do we know, what do we expect, what can be tracked, what can't be tracked. So we'll start outside of we'll start in the outer circle. So assumptions of services that are provided, the first is health and safety. So taking vitals every day, doing what are called precaution checks. So for those of you that aren't familiar, that just means checking on someone every 15 minutes or so to make sure that they're safe. Accessibility. So for people who have special needs, maybe they're in a wheelchair, maybe they're blind. How do you accommodate to those people's needs? Another accessibility example would be somebody that speaks a different language. How do you make sure that they are that important things are communicated to them and that their treatment doesn't become less effective because they can't speak a certain language. And that goes along the lines with accommodations as well. So maybe there's dietary restrictions. Maybe some person is diabetic. How do you meet the needs of the people that are being served in the hospital? The second area is medical. So psychiatric oversight. There's assumptions or there's expectations on how many times a person sees a psychiatrist at a hospital in a week. That medications are administered properly, that when a doctor writes a prescription, that within a reasonable amount of time, maybe by the next shift, that those medications are passed, and that lab work is done. So whether it's for medical issues, whether it's for like a Depakote level or a Clozaril level, that those things are taken care of in a timely manner and can be monitored appropriately. From a clinical perspective, there's a program structure for treatment that involves group therapy, individual therapy, family therapy, and treating individuals with dignity and respect. And this really blends into all of the categories, but we listed it under clinical. So, what are those interventions, those human interventions that don't require medications that are still important? And what's the frequency and quality at which those happen? And then lastly is community support, so making sure that their aftercare plans are adequate, having discharge appointments with a therapist within 7 days, with a psychiatrist within 30 days, and getting referrals to the appropriate providers. So maybe they need more than just therapy and psychiatry. Maybe they need a group, maybe they need to go to a support group, maybe they need to go to a peer-run program. Those are just more of the assumptions we have on the quality of care. Now, many of these assumptions can be tracked using data. They are not all made public, but they're things that the hospital can track. The things that we know about are things like recipient rights complaints, right, Sarah? And
length of stay.
Length of stay.
We probably wouldn't have access to the number of medication errors.
Mm-hmm.
Overall, they might have to do an incident report for us if it was our person, but as far as the quality of their care in general, but that information either can be requested of the hospital, or depending on their accreditation, some performance standards are posted, like JACO has some information made publicly about the performance of different hospitals. And a lot of folks don't know that exists and don't look at it.
Mm-hmm. Right, and so it just depends on the transparency of the hospital or what standards they're held to as to which of these you know about. The self-report measures, if you're not familiar with those, the PHQ-9 is a patient health questionnaire. The GAD-7 is assesses depression, I believe.
PHQ-9 is depression, the GAD-7 is anxiety,
well,
and the CSSRS is for suicide risk.
Right, the Columbia Rating Scale. Yes, mm-hmm. That's right. So there are things. So there's basically three categories. There's things that are tracked that we have access to. There's things that are tracked that the hospital has access to, and there's things that are not tracked that are hard to track just in general because it's a behavioral health nature. So how do you know the quality of the therapist that the individual is working with? How do you know the quality of the group that they're working with? A lot of times, people in utilization management might make assumptions that, well, they're attending group, so therefore that must be helpful. And you would want internal efficacy with your hospital to say that the groups that you're running are meaningful, and you could base that on your satisfaction surveys as to whether they're meaningful, whether they're helpful. But you don't have a way to measure that to say, this therapist provides this quality of group, or even that today's group was better than yesterday's group. Mm-hmm. So those things are still left kind of in the unknown, and those are things to consider that you might want to have a better way to define if you're opening a program that you want to have a similar structure, a basic similar structure to a psychiatric hospital, and that is kind of where the tenets of crisis residential programs fall under.
Yeah, is there a way that, because of course, whatever crisis residential services we provide for our folks, they're going to be excellent, right? And so can we look at what we think is going on at the hospital, do some digging into the data, and figure out what do we want to make sure is being provided at our crisis residential services, and then how can we measure that? Because it will be no good to go to a health plan and say, we have excellent crisis residential services, if we then can't support that claim with some data, some measures that show how that case is made.
Exactly. Yep. So the crisis home, you want to be able to demonstrate its effectiveness, and the way that you do that is by capturing very similar measures to things that the hospital captures. Okay, so here we are so far. We've gone through our considerations. We've talked about our dilemma, our problem, our performance measurement, our inputs, and our assumptions. Now we're going to spend some time talking about what this process looks like within your organization, and who are some of those people you talk to on that journey as you develop a program.
So I don't have to do this all on my own, Travis?
No, Sarah, there's good news. There is help. And it's not in the form of an 800 number. It is people that already exist in your organization.
Yay!
Okay? So the first door we are going to go knocking on is the finance door. We are going to talk to them about a pro forma. For those of you that haven't been exposed to a pro forma before, it's basically a way to understand what the costs would be, like an all-inclusive cost analysis for opening a program or replicating a program. And so we take this based on what we know about programs that we currently operate, and we put it into an estimate. We include how much the staffing is going to cost, how much the food is going to cost, how much the office supplies are going to cost, how much the rent is going to cost, or the construction costs if you're building a real brand new building. All those things come in, so you have a really good picture of what you're kind of taking on. From there, you determine the feasibility. So are we in a place right now that we can take this on? And so generally when you're building a new program like this, there might be a lot of upfront costs, so you don't realize that those costs have made a benefit for several years. Do you have the capacity to do this? So do you have the financial capacity, the manpower? Do you have those things at your fingertips to do it well? Is there going to be a return on investment? Okay, some services aren't known to be very profitable, and so is this service going to be able to at least pay for itself and pay for the cost that it initially that initially existed to get there? And then what are the billing codes for this? So how are you going to be able to bill Medicaid or insurance companies or whoever you're going to be billing for this service? These are all questions that that your finance person can help you to answer, to get a real clear picture of kind of what not just what you're getting into, but what everyone is getting into by committing to be a part of this development. Mm-hmm. From there, you go to visit quality. Some people have quality and compliance in one role. Some people have it separated. But quality is where you're going to really be doing the most identification of data, or have the most opportunities to choose what data you want to use to define the success of your program. So you're talking about short-term performance indicators, long-term performance indicators, all kinds of things, and they're going to feed into this big data window that we have above this slide. But length of stay and self-report measures, satisfaction surveys, whatever it is that you want to identify to make it better. And this is going to be this is great, because if there's things, when you go back to that hospital slide, if you think about that you weren't able to control or that you wanted to measure but weren't being measured, this is your opportunity, to talk to quality and say, hey, I believe that these data points can be captured. They're not being captured in other places right now, but they could really set us apart and show us show everyone how we're doing good work. From there we go to IT information services. We're going to ask them about equipment. What is it going to take to have technology that captures the data that we need? And that might be more than just like a electronic health record, but you might need a certain amount of computers to be able to track the data that you need. Maybe those, maybe the health and safety monitoring that you do in the house, you want it to go immediately into a medical record and not just on a piece of paper to sit and be filed. And you know, maybe your approach is that the more data you can collect, the better, which is a great approach, by the way. We encourage that. But you know, maybe there's easy things to do on the front end to train your staff in how to use technology that make it a lot easier to have, you know, healthy reports with solid information. Maybe that's going to be more helpful to do in the front end than to do later on when you think about it. And IT has done this because if programs have been developed in your organization before, then they have experience with us. So they might ask the questions that you don't realize were important to ask.
The shared reporting development, I think, is huge. It took me quite a while to learn the importance of sitting down with my IT/IS team when I needed data for a new program. Because I thought it, as a clinical supervisor, I thought it was as simple as shooting off an email to my IT/IS department saying, hey, I need length of stay for hospitalizations over the last fiscal year. Or, you know, I need to know the change in locus or DLA score for this group of patients. And what I found after many emails, phone calls, and then eventually actually getting out of my office, walking down to their office and sitting down, is I would often have to sit there with our IT person that would write our queries. They need such specificity in the information to be able to create a report for the supervisor that is actionable and meaningful. They need to know which specific service codes to include and which service codes to exclude, which dates to include and not include. All sorts of things that when you just think in your head what you want, it's not that simple. There needs to be ongoing dialogue and usually 3, 4, 5 revisions of a report before it becomes meaningful and actionable. So this is one where the pace does need to slow down. Typically, developing the infrastructure to have the data you need to monitor your performance in your program, to see if the needs are now being met and your folks are accessing crisis residential and that it's high quality crisis residential, you're not going to be able to bang those reports out in 1 or 2 emails. So I encourage you, find out what your IT/IS staff, you know, do they like chocolate, do they like coffee? Develop that relationship and learn to speak the same language. It will just pay off tenfold in your program monitoring.
Yep, you heard it here, folks. Bribe the IT team. Good. The next door, this is a lot of doors really, but we just put it into one door, is getting the community involved in your shaping process, in your development process. This can have so many benefits because sometimes we find ourselves, we assume that we're the experts, and yet we don't understand the context or the potential of our services and how they can fit into the greater community at large. So often we get our referrals from an access center or maybe from somewhere internal, like a case manager or you know, like an ACT, like team lead or something like that. But we also get referrals from other places because we're not with our clients when they're in crisis all the time. And so seeking out some of those other opportunities to understand how we can have a healthy relationship and how we can meet the needs of the community. The people that know those needs are the other people that interface with the people that we serve. And so ER managers is a great first example of someone to talk to. They are triaging, and their staff are triaging mental health emergencies all the time. So what would they like to see in a service? What would be helpful for them? Psychiatrists, especially ones that currently exist in or currently work in a psychiatric hospital, they are going to be much more comfortable discharging one of their patients if they know that they're going someplace where they're still receiving some level of monitoring, they're still having psychiatry oversight, and you'd be surprised how much you could shorten the length of stay with a patient if, let's say, they were going to be at the hospital for a week, and after day 4, their lethality had decreased, they were still feeling depressed or having some suicidal thoughts. The doctor is comfortable putting them in a crisis residential home, but a crisis residential home doesn't exist in the area. Well, then they're just going to keep them at the hospital until they have more certainty that they can leave. So if you could, imagine if you could put every single person that went into the hospital, instead of having them there for 7 days, you had them there for 4, and you had them at the crisis residential home for 3 days. Not only is it a cost savings, but it puts them in a setting where they have more choices, where it's less restrictive, and it's closer to returning to the community. First responders are another set to talk to. So who are those people, those the emergency workers that arrive on scene when a person is having a crisis or an emergency? And what are the trends that they see in the neighborhood, in the community, in the city that they feel like would be helpful to be addressed? Talking to the Access Center. So the Access Center could be a part of your organization, or it could exist outside of your organization. But ask what kind of trends they see or what they would expect from a responsive crisis services program. Law enforcement is another good group to talk to because they have a lot of exposure to psychiatric emergencies. And lastly, the individuals that you would potentially serve are also really important to get in contact with. What would they want to see in a program, and how could that be helpful? Advisors, there are sometimes advisory boards in certain providers that include people who receive services, because they are going to be able to provide some incredible insight as to how serving someone well and who's in a psychiatric emergency or psychiatric crisis, what that would look like. The next group to talk to is human resources. To talk about when a program's open, how long does it take to hire people? How long does it take to get this program up and running? What are the FTEs? Maybe when you were talking to finance, maybe they budgeted like what the FTEs are. What does that look like in reality? How many full-time people can I hire? How many part-time? What the specialties? How are these people being recruited? What's the interview process going to look like? And then contracts as well. So is this service going to be, back to the triangle slide that we showed about, is it going to be provided by someone else? Do we have a contract with those people? These are just more to like the human component, the people who are specifically going to be providing the services. And sometimes if you're at an organization that provides a lot of different services, maybe services for individuals with mental illness, with substance abuse, with developmental disabilities, somebody who's not involved in the system, they don't understand that there can be some nuances or some complexities to working in each of those different types of programs that attracts different types of employees. And so maybe it's important that you are clear with human resources or with recruiting about what type of individuals you're looking for to work in your program, or the type of individual that would be successful in your program. Maybe someone who's worked in like a call center before, or who's had customer service experience. Whatever those specs are that you think are important in developing a solid program.
So Travis, all of those people that we just visited, now we're going to get to one of my favorite boxes here in a minute because it's a really important box. But those people all come, and those departments all come with wisdom, knowledge from previous years of experience. So it's important to learn from each other, to learn from past, to learn from what our organization has done well or not so well. But we don't want to forget what's in this next box, right? We don't want to just make our decisions based off of our visits with those team members and what we talked about, right?
Right. And so all of these contribute to more opportunities for data. Data! Maybe we'll write a data song. I don't know. Maybe that's going to be 2 weeks. Watch out for the data song, okay, everyone? I think that's going to be, it'll really help to summarize our passion for this. So, so some examples of data that can be collected during this process are the crisis residential per diem rate. Finance is going to have an idea of like what is this going to cost, or what's the charge need to be in order for this to be a sustainable service.
And the per diem rate, just like many of these other data points, in and of itself, it's not so valuable. But when we benchmark it across regional averages, state averages, national averages, that's where we can really get a sense of, oh, we're doing well, or oh, goodness, we are way out of whack here. So remember, one single data point is not going to be near as valuable as if you can benchmark it to the performance of others or yourself over time to show where you fall performance-wise.
Yep. Some other financial-related data points are inpatient utilization and actualized cost savings. So we discussed this a little bit, but how long will it take for your program to break even, so to speak? At what point will it actually start saving money? So that might be, like we said, like a year down the road, 6 months, 2 years, 4 years. Is everyone comfortable with that? Is that the best? How is that going to sit with everyone? Is everyone comfortable with that? Length of stay is another data point, and we kind of talked about these in a different window. Recidivism rate, how quickly do people return either to the crisis home or to the psychiatric hospital? 7 days, 30 days, those types of things. We talked about the measures for self-report. Social connectedness. This is something that's not really measured right now in these systems, but could it be? And could that be an important piece of it? When we talk about the social determinants of health, could social connectedness have an influence on how often someone comes to the hospital? If they had more supports, more friends, more people to rely on, more people that relied on them, would that change whether or not they come into the hospital? Clinical efficacy could be something else that could be measured. So how many groups were offered every day compared to how many groups were supposed to be offered? How many individual therapy sessions, how many family therapy sessions were offered during a person's stay at the hospital? How many ER visits did they have when they were at when they were at the crisis residential home? Often that can happen where information isn't given that's clear, and that goes in the next column there. The accuracy of the referral information can affect whether or not someone needs to be medically cleared, whether or not they have conditions or issues that can't be taken care of at a crisis home, which can delay the process or delay the time that it takes for them to get good treatment, which subsequently affects their satisfaction. If they're bouncing around going from the crisis home to the ER to the psych hospital, could those things have been avoided? Another is the timeline from when a person is referred, like when that phone is first picked up, until they're admitted into the program, and the number of referrals that are received based on source, again, satisfaction surveys, and then NQF measures. Sarah, you're going to talk a little bit about those.
Yeah, again, I mentioned this when talking about performance measures, but when possible, some of your performance measures might just be homegrown, things that are important to you to look at. But when you're looking at identifying your key performance measures or key performance indicators, I really encourage you to educate yourself about the standardized measures that are out there, such as the NQF measures. And maybe even if you're able to just select one to start with. Again, this is going to be the language that health plans speak, that other payers speak, and it will be your way to demonstrate the quality of your services. So for a crisis residential program, there's a few different NQF measures that you might consider. There's one on body mass index screening and follow-up for persons with SMI. So maybe if you're targeting yourself as like a wellness program, you would be looking at that. There's alcohol screening and follow-up for people with SMI. So making sure that you have that co-occurring part of your program. There's a tobacco use screening and follow-up for people with SMI NQF measure. And also we mentioned the PHQ-9. There's a depression utilization of the PHQ-9 tool. These are all standards that are out there that you can look up, how to measure, how to define the numerator and denominator, and start collecting this data so that you have it to share with others. And the other point I want to make about all of this possible data that you can gather, yes, we do like data, and data is a good thing. However, data for data's sake gets you nowhere, right? You've got to be able to use it. So to use it, there needs to be some accountability. So all these folks that you visited along your way as the clinical supervisor, I envision them, and give me your thoughts on this, Travis, but I envision them all sitting down together at the kickoff and before the kickoff to say, okay, what are our key performance indicators? Who is responsible for tracking them? In what time? How is it going to be shared? How are we going to act upon it? Because unfortunately in CMH, we often fall into the role of talking about data. And we can talk about it really good, right? Mm-hmm. But we need to use it, we have to use it to inform and improve our care. And so we've got to have a clear system of accountability and communication and then action or response to what the data is showing us. Right. Which we've talked about in previous webinars, so tune into those if you want more information about that. So,
well, I'm not sure if we're pretty much running out of time. Thank you so much for hanging out with us today as we talked about data in the real world. We will be back again in 2 weeks with another webinar. Thanks so much.